Hey guys, welcome back to Critical Care Academy. Thanks for coming back and joining me. Today we've got an interesting subject. We're going to be talking about chest tubes. So let's get into the action and let's find out what it's about. Hey guys, so on tap today we're going to be talking about chest tubes. My goal for you at the end of this is that you can identify all the pieces, parts, the indications of why we use chest tubes, even how we put them in, and how to manage and troubleshoot chest tubes that you may have. And I think the layout of this is super simple, so this should easily be retainable to you and hopefully make you feel better about taking care of patients with chest tubes. So let's first ask, what is a chest tube? So a chest tube is no more than a tube, exactly like it says, and it's a medical device used to drain air, blood, pus, or any fluid that may be in the pleural space. So chest tube sounds easy, but then you say, well, what's the pleural space? I'm not really sure what that is. So let's look at an anatomy diagram here. So on the right side, I've put kind of just a general anatomy of the lungs. We're not really going to get into all the pieces and parts of lungs because that's not what we're talking about today. So, but I wanted you to see it. I've separated it. You've got 5 lobes there. You can see you've got 3 on the right, 2 on the left, and then it breaks it down individually of all the pieces and parts of the lungs. What our focus is going to be is on this left-hand diagram. When we're talking about pleural space, look at that green ring around both sets of lungs. So that is the pleural cavity. So when we refer to pleural space, that's exactly what we're talking about. And what that is imagine you put your hands together and you've kind of got them pressed together. Now I tell you to kind of rub them back and forth and move them up and down. So it's not the easiest if you've got a little pressure on them because you've got friction there. So this is the same as that pleural space. You've got 2 membranes and then there's a thin amount of fluid inside of that that helps reduce that friction. So as we inhale and exhale, those membranes are able to move back and forth across each other without having much restriction at all. So it's the same as if we had put some kind of fluid on our hands and tried to do it again, then it would be much easier than it would be just pushing them together dry. So this is what the pleural space does, and it helps the lungs be able to inflate and without having any rubbing. So this is where our money is going to be at today when we're talking about all the processes of why we have a chest tube. So let's talk about why we may have a chest tube. What are the indications of having a chest tube? So I broke it down into 4 basic categories here, and these are going to be the ones that you'll see. And I think once we look at them separately, you'll have no issues. So a biggie, probably the biggest reason, is called a pneumothorax. And think about that as air. So there's air now in that pleural space that has basically pushed on that lung and made it collapse. And it may not be fully collapsed. You can have, a partial collapse. But either way, there's air invading that pleural space, pushing against that lung, not allowing it to fully inflate and open up. So some of the causes: chest trauma, penetrating wounds, lung diseases like COPD, cystic fibrosis, things of that sort. And then sometimes we don't exactly know what causes a pneumothorax. We just know it's there and we can't identify why. So I would say, stepping back down, this is not as common, but hemothorax. Think about the word hemo, meaning blood. So there's now blood in that pleural cavity. And then, all these have the same end result, as we need to get them out. So this is just identifying what each one of these causes are. So chest trauma, coagulation or bleeding issues, post-CT surgery, lung infarction. So if you had a clot and it caused a part of your lung to infarct, that would be one good indication of a hemothorax. And then also lung cancer. This is probably one of the more seen reasons for hemothorax. Um, Next one is an empyema. Very interesting name, but this is pus that has collected in the pleural space. I know, sounds pretty nasty. So, reasons for this, you can have chest trauma, bacterial pneumonia, TB, post-surgery complications, or lung abscess. And then the last one is pleural effusion. A lot of people probably see this when they read chest x-rays, and basically that all is saying that there's fluid in the pleural space. We don't necessarily always know what the fluid is, we just know there is fluid there. So causes of this can be heart failure, PEs, cirrhosis of the liver, also post-CT surgery, and pneumonia. So these are your basic 4 indications of why somebody would get a chest tube. So let's take a quick look at a picture that kind of breaks it down for us. And this one just happens to show a pneumo and a hemothorax. So if you'll notice on the left-hand side image, so we've got the lung here, and it's sitting here, but now we've got this outside ring here. All this here is air, and it's pushed our little lung to a minimal size. So, and then if you look at the other one, we've got our lung sitting here, and then all this in the bottom base here. This here is all blood. So this is a hemothorax. So I just wanted you to be able to see kind of what that looks like if you could go through and get a visualized image. So the image on the right is actually an x-ray of a pneumothorax. And if you notice, it's separated out nicely so you can see it. But look how much like crisper and clear on the, well, it's on the left, but it's actually the right side lung, because it's all inverted on an x-ray. So look at this side over here. Look at all this area. So this is nice, crisp, clear, kind of blackened image. Versus over here, you notice it's got all the striations and kind of fuzzy look to it. And that's because that lung is fully inflated and you're seeing kind of all the pathways in the lung. This one, this is all just air on the right hand side. So it shows you how much more condensed that lung is on that side, because all the pressure is pushing it down and it cannot inflate. So that's a little bitty lung. So now what are we going to do next? So we need to put in a chest tube, right? So you've got your doctor's orders is, let's make sure we get all the setup for a chest tube. So there's a couple ways, and in here I've just thrown a couple pictures in of what you would need, pieces, parts. So this chest tube kit, and this is going to depend on what your provider wants, right? So if this is something that he can use a smaller chest tube for, there's a lot of facilities that have chest tube kits where everything comes in the kit. So like here, this chest tube kit has got everything you need. You've got a tube, you've got wires, you've got needles, you've got dilators. These right here are dilators, and then you've got your wire, and everything you need is essentially in this kit. And they'll come on the package and they'll say, you know, this is a 20 French, and it just depends on the size. A lot of your bigger stuff, like this trocar and tube right here, this one I can't remember exactly, but I think it's around a 32 French. So it's much larger in size, so it's not going to come as a whole kit. So this is going to depend on what your provider wants as to what you need to grab. And they'll clarify, they'll say, you know, get me a kit with a 20 French chest tube. And this is also going to depend on what you're getting out. Can you use a smaller chest tube on, you know, thick, viscerous empyemas that it's going to take a pretty good sized tube to drain? Probably not. If it's just a little bit of air, we can probably get by with a smaller French tube. So first and foremost, you need to decide, what do you need from the provider's standpoint. So on top of that, you're going to need to grab an atrium or whatever collection device you have at your facility. So this is what's going to collect the fluids. If you have fluid that comes out, it's going to collect it in the chamber, and you're going to be able to set all your stuff up. And then you're going to need suction set up, more than likely. Now, you don't always necessarily have a chest tube hooked to suction, but a lot of times you do. They can be hooked to gravity, but in this case, we're going to go ahead and get everything ready for suction. That way we have everything. You don't want to be that one that doesn't grab everything that you need along the way, and then they're asking for stuff later. So as we get all this, let's talk about the collection device. So this looks like a lot, yes. And if you've never used one, it feels like a lot. But it's not that bad once you get to knowing the pieces and parts of it. This is a very straightforward system, and I think let's just kind of glance at it and you'll figure out what I'm talking about. So let's start with simple. This leg on the bottom, right here in the yellow, this is, it. When you get out of the package, it's flat against the bottom. So basically you're going to take it, turn it out, and that's going to give you a leg on both sides. And then that's what you're going to tape that leg down to the floor. I can't tell you how many chest tubes I've about kicked over because they weren't taped well to the floor. So that's an important piece, as silly as that seems. So move up here. Now you've got your fluid collection chamber. So you'll notice it's into 3 different chambers essentially. And basically what it'll do, it'll fill up through the top, and then once it gets here, it'll drain over and it'll start here. And then after that, you'll move into here and you'll fill up with a maximum capacity of 2100 milliliters. So, and that can happen fairly quick. So depending on what you're actually draining and the size of it, you may want to have an extra atrium or collection device handy. That way, if you need to switch one out, you can. So next part in the pink up top, you're going to notice you have a tube, and this is kind of tucked in the back of it. It's not very well visualized here. But this tube is what's going to connect to the actual chest tube that's in the patient. And it unfolds, and it's pretty lengthy once you get it undone. So let's move over to the top is your suction gauge. So you're going to have an order, and let's say your order says, let's set it to -40 millimeters of mercury. So right here where this arrow goes into the side of this, there's a wheel on the side that you're going to be able to turn, and when you turn it, this yellow marking is going to turn to any one of these numbers. You just have to roll it until you get to where you want. And that's going to set your suction on the atrium itself. Now, yes, you're going to have it hooked to the wall, and the one on the wall, let's say you have it at -80. This is going to limit it to -40. Whatever you have on the wall should be well over what you're trying to do here, because you never want less on the wall than you're trying to get out of this. So let's say we set it to -80 on the wall, and then we turn our little dial, and then we're eventually going to turn it right here to the -40, right? Now that we've got that set, now your suction from the wall, I didn't really say anything about it, but it's going to come in right here. There's a little port right on the top of that. That's where your suction is going to go when you get ready to hook it all up. Now, before you do your suction though, one thing I didn't tell you about before, on the bottom we talked about water seal. I've got it marked here. See how that water is bluish tinged? On the back of this whole collection device, when you get it out, there's going to be a little plastic bottle of water, and it's going to be perfectly sized. You take the top off, and you're going to put it right there in that suction port on the top. Squeeze all the water out into that. There's a blue dye in the bottom of the container already. So once the water hits it, it now turns blue, just like that. And then last thing you want to verify once you get your suction hooked back up onto that is this suction ballast right here. This guy, once you get suction, it's an accordion style piece, so it should pop out and cover this window here. And that is just giving you feedback now that you actually have suction on the canister itself, or on the atrium itself. So that's pretty simple. Once you do this once, twice, you'll say, gosh, this was nothing. This is easy to set up. So now that we know the parts of the collection device, let's look at placement and what that entails. So we've got a couple ways, and this is just like the kits that we talked about. Are we using a small tube or are we using a big tube? And that's why I put two images here of what it takes to do both. Now this is not a super in-depth picture of both, and we're not going to go into super in-depth of how the whole procedure goes, but I want you to know. So this image on the right, you'll notice it's got a picture of a needle poking into the pleural space, right? So that needle will poke in, and this is your provider doing it, and they know landmarks of where and what they need to drain. But once they insert the needle, they will then insert a guide wire that comes in through the needle, and that's what they're going to use to start putting in the dilators, and then eventually your chest tube will slide over that same wire. So wire goes in, you pull the needle out, and then you slide a dilator. You stair step it. So you start with a small dilator. You'll slide it over the wire. It goes all the way down, kind of opens the hole a little bit. And then you may do this a time or two more with bigger ones. And then in the end, you're going to slide your actual chest tube over that same wire. And that chest tube is going to go in, and it's going to sit in this space here now. And then basically, you're going to have a tube that's left out here. So you'll slide your wire out last once it's all said and done, and then the provider will go in and suture that tube into place. So that way it doesn't move or pull out, hopefully. So this is for your small tubes, right? We're going to write small across the top just to help remember. Now look here. These can be your large tubes. Now, notice the difference here. They're making a cut here with a scalpel, and that cut just depends on the size of the tube. It can be, you know, 1.5 inches or better to make a slice in. Now they're using, in these kind of sequential steps here, they're using forceps here to go through their cuts, and notice how they're widening the forceps up. That's opening kind of that muscle and subcutaneous layer and kind of breaking through that area and making a hole. Then you can see in the last picture, they've got their finger in the hole. So that seems kind of barbaric, but you know, as far as feeling the right space and where you're at, that was one of the go-to ways to do it. And then either with a pair of forceps, once they figure out placement, they either take the tube in with the forceps, or they can actually feed it in with their finger still in there and make sure that they feel like it's in the right place. Now, look at the pictures on the bottom. This kind of shows you where your tube comes in, and this is, we'll just call this a pneumo here because it looks like airspace. And look how much more collapsed that lung is there. Now, once the tube's in, it's going to, a lot of times when they put a tube in for a pneumo, you can hear a gush of air coming out as they get it in. And it almost sounds like opening a soda pop bottle. You just have that initial rush of air. If it was a pleural effusion, then you would start seeing drainage come out, or hemo would be blood coming out. And then that's going to allow that pressure to equalize and then allow that lung to reinflate. And you're going to notice a big difference, hopefully, in your patient condition. Like, you should start seeing these symptoms resolve, and they should start feeling a lot better. But on the sidebar, I put everything that we would need for placement, because a provider is going to say, get me a chest tube set up. And you're going to say, okay, sure. And you're going to say, I don't remember everything. So chest tube kit for the small ones. They may ask for a thoracotomy tray for their bigger ones. That's going to come with all your tools that they would need, those bigger forceps like that, and kind of retractors if they had to use that. But those are your kind of two options. Think about them between small and large. And then you're going to need your atrium or your collection set up. Suction, if you're going to be doing it to suction. Anesthesia, lidocaine, stuff like that. They'll let you know what you need. Some of the kits come with it already, but if they don't, they'll say, hey, I need X amount of lidocaine, and we're going to numb that place. You'll need a suture kit for the end, and then you'll need sterile gloves, gowns, drapes, towels. Kind of think about a whole sterile field setup. And then if you're going to be using a large bore chest tube, you're going to need whatever size they want, and it comes on a trocar already. Trocar is just basically a metal pole that they can use it to push it in if they want to. It takes a lot of force when they're doing it with the big tubes to get it in place. And remember, sizing on the tubes, I know it's confusing because between IVs being small numbers, bigger IVs, and then you got Foley's with their sizing. These numbers, the smaller the French, the smaller the tube. And as the numbers get larger, so do the tubes. So you can go with a 16 French and it's a little bitty tube, and you go up to 30 plus. Those are big tubes. So just kind of keep that in mind as they are telling you what they need. All right. So after that, let's go to management. So this is where I think for nursing, this is huge because let's say, a provider puts all this stuff in, right? And we're there to assist. But management is something that's in your hands once everybody's done. Everybody walks out and they just leave you with it. So a couple key points I want you to remember and how to properly manage this and make sure you are doing the best thing for your patient. So you're going to regularly monitor the output or the drainage and what is the characteristic. You want to know what that stuff looks like coming out. And then so you're going to maintain aseptic technique during dressing changes. And then you want to make sure that you're constantly checking to make sure your tube is unobstructed, it's not kinked, they're not laying on it. That way it has the opportunity to drain. So always make sure your orders are what you're doing. So if it says negative 40 millimeters of mercury for suction, you best be sure that that thing is hooked up to suction. You don't want to be on the receiving end of that being set to gravity and your provider comes by and says, why is that not hooked up as I ordered it? So check your orders. Make sure you've got it hooked up the way that they want it hooked up. So assessing for signs and symptoms of infection or possibly a pneumothorax if something malfunctioned with the tube. I think that's pretty important. You're going to be seeing chest pain, chest tightness, extreme shortness of breath, rapid heart rate. Their SATs are probably going to be in the toilet. Could be possibly cyanotic. That's one thing we didn't really talk about signs and symptoms before, but those are the things you want to look for in a patient that's got a chest tube. That way you're ensuring that they're not going backwards as far as the care. And then a biggie for me is always keeping the supplies at the bedside that you might need. Now, that's not saying that you have to have them and you're going to use them, but it's better to be prepared than unprepared. Trust me at that. So, you need large clamps, you need sterile water bottle, you need Vaseline gauze, 4x4 dressings, and tape. And we're going to talk about why you need those specific things here in just a second. But I just want you to look at this and say, these are the things I need to do in taking care of this chest tube. So while we're talking about management of your chest tube, let's talk about what the heck the bubbles are. I think this is one of the most construed things about chest tubes is people just don't understand why or what's normal or what's not normal. So when we're talking about the bubbles, so if we're putting a chest tube in for a pneumothorax, let's say, would you expect to have bubbles after you put that in? So yes, you would, because we're removing air from that pleural space. Air coming through water makes bubbles. So that would be a expected thing to happen, is to have bubbling in your water seal chamber after putting a chest tube in for pneumothorax. And is it okay to have intermittent bubbling? Yeah, because sometimes you get most of the air, but then there's still some trapped in there that you may not get till later. So you may see some intermittent bubbling, and that's okay too. So those would be expected things. That can also be a continuous bubbling for a little while until that all that air is out. You'll notice on the picture or the diagram you've got steps 1, 2, 3, 4, 5, and they kind of stair step down and away. And that's how we rank the severity of the air that's coming out, whether it's an air leak. Um, and, so unless it's, a 4 or 5, that's pretty heavy bubbling coming out, and you'll know because it's going to be splashing and sloshing around. Those are kind of what I would look for as unexpected. So when you start having those heavy bubbling, think probably primarily you've got an air leak. Look and check and make sure your tubing from your collection system that connects to the chest tube has not come undone, because if it comes loose, you're just sucking in the atmospheric air and it's pulling it through there because it's on suction, more than likely, and it's bubbling like crazy. So that's an easy fix. Um, is there other things that can be more severe? Yeah, certainly. Maybe you have a issue with your actual lung itself, and there was a bleb or something that has popped, and now you've got this continuous inflow of air and you've got this heavy bubbling. So you'd want to contact the provider. If you can't find an air leak and this is a big change, you didn't have any of this bubbling, and then now all of a sudden you do, make sure they're aware so they can assess it and you can move forward with whatever you need done. Um, Titling is something we'll talk about just real quick. So you'll notice sometimes that the water chamber, you'll have it where it fluctuates up and down. This is called titling. So this is where the water seal is moving with kind of the pressure inside of that cavity. So as they're breathing in and breathing out, you might see that water level kind of dip and rise, and it coincides with their breathing pattern. So this is completely normal. This is supposed to happen. So nothing to be alarmed there. So let's move on past this and move on to what kind of complications we can have. So let's talk about what are some of the possible complications of having a chest tube. Um, generally, yes, they are pretty safe, but if you think about it again, we're taking and cutting into somebody and kind of stabbing a tube into them. Yes, it's a necessity, and yes, they need it, but everything comes with a complication, right? So, as always, anything we stick in somebody, you have a risk for infection at your insertion site. Um, Bleeding is a big one because we're taking and putting this into somebody, and we're most of the time having to cut into them. So, bleeding to the vessels around or possibly organs. And think about insertion. We sit, depending on how low they're putting that chest tube in, let's just say, for sake of, you know, kind of quick and easy drawing here, we've got a lung here, a lung here, and you've got your diaphragm that sits here. And then enclosed is your thoracic cavity. So let's say that their site they were trying to go is here. So think about puncturing here. You could potentially go through the diaphragm and into that abdominal cavity there. It's not done a lot, but just know that there's risk with that. I mean, and just a little interesting tidbit. So when you're feeling placement for insertion, they're going in between the ribs. Interesting to me, on the underside of each of your ribs, you've got venous vessels, you've got arterial vessels, and you've got nerves, and they all run underneath the rib. So the ideal placement is above the rib, because then you start avoiding all those key components there. You don't want to put it in on the underside and nick one of those arteries there, and then you've got a huge bleeding problem, potentially, depending on your coags and stuff like that. But I just thought that was an interesting fact. Shoot on top of the rib versus underneath. And then a complication post placement is going to be dislodgement or accidental removal. these things are sutured in good, they're dressed good, but as just as well as I do, people move around, things get caught, there's all kinds of things that can happen, and one of them could come out pretty easily. So let's talk about what would you do if that were to happen. So we'll call this when things go sideways. And anybody that's worked around them knows this is a real life thing. It happens at your least convenient time. And you just need to be prepared. And this is where your supplies come in. This is an easy to handle thing. I just want you to know, what to do. So this is one of the scarier things to happen. You're in your room next door and they're like, oh, hey, they called and said they ripped this tube out. Oh, well, okay, so go running over there. We need to see, is it separated from the actual chest tube? So this is, your chest tube is still inserted in the patient and the collection tubing has just pulled apart, because in between you just basically have a 5-in-1 connector that connects the two. So they could have turned and just pulled that loose. So that's your separation. So separation is easy. So there's two methods of thought here. Kind of older school thought is you clamp the chest tube with a big pair of clamps. And then a newer school way of doing it is you take the end of the chest tube and you put it into a bottle of sterile water. And that's one way it's come about in the last little bit. But you think about it, it is sterile, so it's not going to be dirty inside of that. And then the water itself creates a seal to where no air is going to be pulled into the pleural cavity, but air could still escape through the tube into the water. So either which way you do it, if you have the clamps, clamp the tube or submerge it in the water. You're going to take your old collection system, because it's dirty now because it's been disconnected. You don't want to connect something that's been in the bed back into a straight line into the pleural space. That's asking for an infection. So we're going to discard that system. You're going to get you a new one. You're going to open it and you're going to set it up just like we talked about before. And you're going to put it on the floor, set it to the same settings, and then when you get all that done, you're going to connect it back to your chest tube. Either take it out of the water or go ahead and connect it if you've got it clamped. Go ahead and connect the two. Make sure they're secure. If you're using the clamp, unclamp the tube. I know it's a simple step, but it's one of those things we feel accomplished, we fixed it, and then we forget to unclamp it. So make sure the clamp's off. Now, what about if that same scenario, but they've ripped the whole chest tube out? Now you've just got an open wound on the side of their chest wall. Seems pretty scary, right? So fix for that is going to be, so you're going to take the Vaseline gauze that you've got at your bedside because you're a good nurse. You're going to put the Vaseline gauze over the hole, and then you're going to take a 4x4 dressing, and then you're going to put the 4x4 on top of that. So it creates a layer over top of the Vaseline. And then what you want to do is you want to tape 3 sides, and preferably silk tape, like wide silk tape if you have it. And then you're going to contact your provider. So big question as to why do we do a 3-sided? Why don't we want to tape the whole thing? So remember, you still have this opening into the pleural cavity. So you want air to be able to escape. So let's say we have our skin here. Here's your hole. And then we put our dressing over top of this, right? So we put it here. So now if we had all 4 sides and air was trying to escape out through the hole, it wouldn't be able to because we've got it all locked down. With 3 sides, if it had to push air out, it could push it out the side that's not taped. And then as it tries to pull air back in, this part will come back down and shut it off. So it works like a flapper valve. I can blow out, but when I try to pull it in, it pulls it down tight on the skin. So it's a fix until you contact your provider and figure out what your next steps are. All right, guys, that's another one in the books. So chest tube down. I hope we just took your knowledge from here to here on chest tubes, comfort level from here to here on chest tubes. It was a topic for me that was really sketchy at the beginning, and I always felt weary about it. So I'm hoping that this was an easy breakdown and super simple to understand. If you have questions about it, let me know. I'll be glad to help you in any way, shape, or form. So as always, I really appreciate you guys coming and watching. Hit that subscribe button for me. Let's make this grow. Let's take this channel to the next level too. Don't forget to check out the merchandise on the website. We've got some pretty cool stuff out there. And then, as always, keep up the strong work, and I'll see you next time.